Okay, while you guys are getting your Q&A sorted, I also just wanted to point out, so the immunization schedules that Jan recommended, or talked about in terms of the WHO recommendations, are part of a SMART guideline digital adaptation kit, and you can see a draft of this here. This is the L2 requirements, so if you're interested in this, we can share this and you can take a look. We also are in progress for the L3, the fire side, and that should be hopefully ready by Q1 of next year. So in this session, we're going to talk a little bit more about architecture and technology and how those can fit in to achieve some of our goals. And there we go. So first of all, I just wanted to welcome my panelists, Dr. Maria Jose Letelier and Dr. Jorge Pacheco, sorry, and Dr. Olegas Nyaksu, who will give us some examples of using infrastructure, digital public infrastructure, and architecture for their countries and regions. We do have some resources that are linked related to the first part of the presentation, and you'll have access to all of these. But let's maybe just recall a little bit from yesterday, and for those that might not have been here yesterday, we're talking about digital public infrastructure, which has a few different layers. There's a technology infrastructure, like the internet, the power, et cetera. On top of that, we have foundational digital public infrastructure. On top of that, we have health-specific infrastructure, or we did, and then our infrastructure has disappeared. And on top of that, the health-specific infrastructure, we built our application infrastructure. And you can think of these as sort of building blocks, Lego blocks, for building the applications on top of all of these interconnecting systems. So does everybody know the hierarchy of needs, where you have like food, water, shelter, then you get to power, Wi-Fi? I think our needs are a little lacking at the moment. So we've got our Lego building blocks, right? For our foundational DPIs, our sector-specific DPIs, and our applications that we want to build off of this. So when we looked at the health sector specifically, we outlined a couple of DPIs for H, or DPIs for health, that were based on the OpenHIE architecture. And so we reviewed some of these yesterday. The foundational level, we have things like digital identity, financial transactions, trust networks, et cetera. In the health sector, we have shared health records, logistics systems, terminology services, client registries. So we've got a number of components, and on top of that, we build our applications. So, well, if we want to think about how do we actually bring all this together and actually make a blueprint and understanding of what we want to do to take these building blocks and build something, we want to look at the enterprise architecture. And this is one common framework called TOGAF for approaching and documenting architecture and the requirements and the needs. And you can see it's sort of a continuous process of you set your vision, you go through business architecture, information systems architecture, technology architecture, go through opportunities, solutions, migration planning, implementation, architecture, change management, and back to your vision as you go through this sort of cycle. So the TOGAF, if you're not familiar with it, is a very structured and way to look at and articulate the architecture for your entire enterprise. We're not going to focus too much on TOGAF today, but I just wanted to highlight that as an approach. But you know, when we have all these building blocks, we do need to figure out how to fit them together. Like with this one Lego set, you can create 3 different little sets from the same building blocks, right? We have the giraffe, we have the lion, and antelope, I guess. Is that an antelope? So there is no right way to put all these building blocks together. It's really about what you're trying to achieve. If you're trying to achieve a giraffe, you put it together one way. If you're trying to achieve the antelope, you put them together another way. So you really just first need to figure out and articulate what are your needs for your enterprise architecture. You can't necessarily do them all, or meet them all at once, so you need to prioritize them. And then you need to articulate any constraints. Maybe we have no connectivity in some of the places that we want to deploy, or maybe we're doing a vaccine campaign versus doing vaccines in a clinic, and that might have different types of constraints in how we approach our architecture. In any case, we use sort of our blueprint in this implementation plan to get a sort of phased implementation plan of how we actually deploy and put these pieces together, which you sort of see on the right-hand side, right? So you've done Legos before. You know how this works. So what actually makes the Legos work as a building blocks is the specifications. There's certain dimensions for the size and the shape of the Lego pieces and how they fit together, right? So that in the orange on the right-hand side, you can see that that's sort of the crucial piece to making all these building blocks work together. So now, what's the analogy in the DPI sector is we just need standards for our building blocks. So let's take one key business process as an example and just sort of work through where the components come in and what specifications and standards you need for your Lego blocks. And this will help you determine which technology solutions that you have. If you determine the specifications, you can say, okay, do I have the technology solution that meets my requirements from the architecture? And you can drive and have good choice of what technology solutions you have by having clear requirements. So in this case, our key business processes, you wanted to pull a digital vaccine certificate system for people that are getting vaccinated, and that you want this to be able to be used across borders. So if you sort of take that business process and start taking it apart, one of the things you'll notice you'll need for that cross-border provenance, the verification of that digital vaccine certificate, is a trust network. You need the individual countries to be able to trust each other and trust the health documents that are received. And so that sort of becomes one component that we need in realizing this cross-border vaccination certificate use case. And you can see on the left-hand side, a list of the specifications. We're not going to go into detail here, but these are the specifications for the trust network that help define that building block. Okay, so we have some coming from ITU, which we mentioned yesterday, some coming from another standards development organization, W3C. WHO has some guidelines on how we're operating our trust network that are published. IHE, it's another standards development organization that has another profile that's in progress. And finally, ETSI, which is the European Telecommunication Standards Initiative, has some specifications on how to sign and health documents or documents in general. So these sort of specifications make up these building blocks. We could also say, oh, well, how do we actually use this? What's the user story of the person going and receiving their vaccination certificate? Well, they go to a health clinic, they get recorded in the EHR system, and a certificate gets generated for them. So we need to have some way of giving that certificate from the EHR to the user, to the holder in their digital wallet. We also need to have some way so that that certificate is signed within that trust network. So we need to link these systems together, and the standards on the left-hand side are some of the ways that you could try to bring these building blocks together and help define the requirements and the components that you need. Then we could say, oh, well, maybe optionally we also want to say, report to our HMIS system on the number of vaccines that were administered in a facility over a time period. Okay, there's specifications on how to do that that are independent of any particular software system, such as ADX or MADX. You might also say, okay, well, it's great that the person gets their certificate, but we also want to see these at a central national level. Maybe we want to have a national scheduling service so we can do reminders of, hey, your child looks to be due in 2 months for a vaccine, or you're overdue. Or maybe somebody loses their vaccine certificate, you need to reissue. So there might be a business need to have a centralized registry. So again, there's standards to how health documents could be shared from an EHR into a centralized shared health record. And you could think of the immunization registry or national immunization registry as being a very specialized shared health record. So next you could say, oh, optionally, I want to use a national ID, a national health ID, or a foundational ID. So then we have the specifications for how you link to a client registry or a digital identity system. And so you can see some of the specifications on the health ID side and how to get these IDs. So you sort of bring together the components that you need based on what and the standards that you need based on the business processes. And finally, so sometimes you have local codes. You might have systems that are using their own codes and there's no national coding. There's a national code that you want to use or a global coding system or the vaccines. So you might want to introduce a terminology service. And so there's, again, specifications and how to interact with a terminology service to say, translate my local code or the code that this particular EHR is using into a nationally accepted code. And finally, I think this is the last one, is you want to ensure that you have the stock on hand before you vaccinate the child. And when you do vaccinate the child, you want to update your inventory. So there's some FHIR resources, the immunization and inventory report, which you can use for these types of business processes. So if these things are requirements for you, as you think through your immunization infrastructure and architecture, you can start putting together these building blocks one at a time. You might not want to do everything all at once, but you can stage it based on needs and priorities. But this sort of breaking this down in this way helps you manage not just at a technical level, but from a governance level and a project management level, what you're going to be doing. So with that, I'm going to turn it over to Maria. Yeah.
Hello, my name is Maria Jose Letelier. I come from the Ministry of Health of Chile. I am the head of the digital department in the Ministry of Health. And today, we am provide to an overview of Chile's progress in developing its digital public infrastructure for health. To contextualize it, we will begin with a brief summary of the country key characteristics. Yeah, no, yeah, okay. Okay, this is our context. Chile's population is approximately 19.5 million, with over 85 residing in urban areas. Healthcare systems structure is a mixed model where the public sector, FONASA, serves 80% of the population, and the private issuers, ISAPRES, cater primarily to highlight income groups. Internet penetration is high, with 91% of households connected, and mobile device penetration exceeded the populations. Adoption of the electronic health record is widespread, 94% in primary care healthcare centers, 75% in a hospital, 79% in emergency departments, and 56% in surgical facilities. The legal frameworks for the digital transformations since 2005, Chile has implemented a comprehensive legal framework to drive digital transformations and enable the interoperability and secondary use of the health information. Key regulations include DFL1, sanitary code that provides the legal foundations for secondary use of health data in areas such as public health surveillance, service monitoring, and statistical analysis. In 205, law establishes the patient's rights and duties, including the regulations on accessing electronic health records data. In 2023, the law governs the provisions of the telemedicine service, ensuring quality and accessibility. In 2024, we have 3 laws. The first mandates interoperability among public and private healthcare providers, aligning with the Ministry of Health standards. The second modernizes the personal data protection regulations to align with a global best practice. And the last one, introduce cybersecurity standards for the safeguarding health and data and systems. Yes? Now, we advance with the data maturity. Chile has demonstrated significant progress in improving the maturity of its health information system. Over the past 3 years, 2 evaluations under the IS for Health framework has been conducted, with the Chilean progressing from score of 3 to 3.5. This expects improvement in data governance, interoperability, and digital health strategy implementations. But, okay. Okay. But historically, telehealth systems faces interoperability challenge, with different systems operating independently. This lack of integrations required healthcare professionals to input data redundantly across multiple platforms, leading the inefficiency and the delays. Now, okay, this one. But now, Chile's architecture is the local system and the back are connected through the interoperability layer using FHIR. In the interoperability platforms, we have a master patient index, a centralized clinical data repository, and we integrate with a national system, for example, education, justice, regulations, institutions, insurance, etc. Health data can interact with the critical national system, enable comprehensive insight for a public health decision makers and service delivery. Data is accessible via dashboard in the top, via dashboard for a public health decision maker and for a patient in a portal and in a future in a mobile app, ensuring continuity of care and empowerment patients with their health information. Our architectures and governance, Chile Digital Health Architecture follows hybrid models, centralized and distributed to manage the information assets while ensuring data mobile within the healthcare network. National governments is overseen by the committees that includes the representatives or IT, health statistics, and digital health department, chaired by the Ministry of Health. That is my part. We continued with Jorge Pacheco. Jorge, that's yours.
Hi, my name is Jorge Pacheco. I am the head of the Department of Statistics and Health Information in Chile. I'm going to present two information systems that we are working on. One is the electronic immunization records. And Chile has electronic immunization records since 2010. We have 14 years of information. Now we have more than 200 million of registries there. We connect in this system is used by more than 2,000 health facilities, and it was widely used during the pandemic. And using this information, Chile developed the digital pass, this digital certificate of vaccination, and it was used during the pandemic for the move of the people between countries. Also, this system permits us to evaluate the immunization program. This year, the Ministry of Health implemented an immunization strategy using nirsevimab. This is a new medication for respiratory syncytial virus. And we can see the impact of that immunization strategy in the hospitalization of newborn and infants there. So we can use the information of this electronic register and use also the information about hospitalization. And we can know, for example, and to produce real-world evidence about this medication. And that are the preliminary results of the immunization strategy. Also, we have been developing another information system. This is the referral system when the people move from primary healthcare to hospital. And we can track the person using information of the electronic health record. This information system is built on FHIR. We have now 40,000 referrals, patients that are being tracked between different levels. We are connecting 85 primary healthcare facilities, including rural health facilities, with 5 hospitals. And this is growing fast, and we expect to have a national coverage at the end of the 2025. Also, Chile worked at a regional perspective with the Pan American Health Organization, and we are participating in a lot of projects that they have. Particularly, they are the I think it's there. And particularly in these three projects, the vaccination certificate for yellow fever, the international patient summary, and cross-border telehealth that are developing at regional level in Latin America. So thank you very much.
Hello, everybody. It's good to be back to Africa and super excited to be here in Kenya. That's my first time. I'm coming from a cold European country called Lithuania, and I will try to present a little bit of our experience and our lessons learned on digital health architectures using FHIR and how it all helps to improve healthcare. So a little bit about us. I'm quite aware not everybody knows where Lithuania is exactly. So you can see on the map, we are a small, tiny country together with our neighbors, Latvia and Estonia. My colleagues from Latvia are sitting also here. And we are actually, as you see from parameters, quite a small country. But nevertheless, you can see the bolded lines that we have National Health Information Exchange based on HL7 FHIR since 2015, and since that time, if we speak numbers and you compare population to a number of structured units of data, structured clinical documents, we have quite a number. So this includes e-prescription, e-referral, and many other things I will talk soon. But most importantly, during these almost 10 years, we learned quite a bit, and I think that could be interesting experience to learn from. So I want to start with a joke. You know, in Europe, very often Lithuania is, and Latvia and Estonia, European countries speak about digital labs. We're small countries, and we're quick to adopt changes. So when I visit Germany or Austria, they're kind of jealous. Oh, guys, we're discussing, we have these lands and all this complexity, and you just do things. But in the reality, in Europe, we have a situation. You see the quotes from the newspapers from many countries. So you will see public opinion, regardless what we tell beautifully during conferences, but something doesn't work, something is not efficient. And if we see Lithuanian one, it will be, oh, it doesn't show. Okay, some animation doesn't work. Our quote from the newspapers of Lithuania would be, e-health doesn't work at all. So it's very interesting perception. Sometimes we are very harsh inside to ourselves, but in the reality, what does mean this conservative narrative from the mass media is just willing to have more. To have more efficient things. And now you will see reality, what we have made, what system we have, what architectures we have. So as you can see from, maybe I will change the microphone. You can hear me. All right. So as you can see, we started like many countries from national registers. And when we continued with these building blocks, as it was nicely explained yesterday by Dr. Honey and many others of DPIs, which basically brought us to creation of digital health platform, which enables us to use e-health services such as e-prescriptions, e-booking, e-referral, do portals and other health applications. So as you could see, this sign HL7 FHIR, that means that we've been early adopters. And back in 2014, we made a very, very brave decision not to use golden standard back then, as our friends in other European countries, which are IHE profiles and HL7 version 3, which would be a standard way. we decided to use something brand new, something which nobody used yet, and it was called HL7 Fire. We're talking today. So, been quite a lot of specialists who were against. I was one of them. But looking back, we can say that it worked out. This standard as a glue, as interface between system really, and this conference shows that, really takes central place. And really our system, you'll see the numbers, is working, take-up is growing. And basically how we made that, it's not only in adopting FHIR resolves your problems. I think my colleagues would agree. It's creating all ecosystem of legislation, governance, financial instruments to really empower usage of interoperability. So you can see, but in our case, as an example, all healthcare facilities are mandated to use FHIR interface. If they cannot, they don't have funds, we provide them free of charge tool, which is a mini EMR system. We call it online portal. And in that way, not one facility would be left behind. So if you cannot do your HS integration, like in many countries, we have all this investment. I hear of my colleagues from Zambia and other countries, but what we do with all our old technology, right? So some of them can integrate, others not. For those who cannot, most probably we need to provide a tool set, right, for the doctors and healthcare specialists. So what our national EHR has today to offer patients and doctors, you can see on the screen, so we spoke about immunizations. We do have immunizations digital, almost 100%. We have certain services as immunization plan, which is not regretfully used very well right now. But as you can see, this initial set is currently growing, and very soon this year we'll launch another 40 different types of clinical documentation. In terms of numbers, that's a very insightful slide. If you see here 2016, just after the start of a national EHR, you see take-up is very slow. So it's not enough to publish API, to embrace. You really need to encourage people to help them to integrate. So slowly, slowly, we are with these numbers, which are quite high. So if you see a number of almost 100 million records, digital health records for population of less than 3 million, that shows something, right? So what we have achieved. So I will not read that, you can see yourself. So we have quite good numbers in main clinical assets, which we define as essential for our health system. But also we have certain digital applications which we successfully implemented. So for example, everybody is speaking about e-prescription as essential thing, but what is the next thing to make usage comfortable is integrating with online purchasing, right? What to say about e-booking system, right? So we want national booking system like Malaysia showed us, so we have quite similar system in Lithuania. I'll give you just an example of our patient e-booking system. So we had these goals on left of you, which are outlined. So basically, as in every European country, we do have, and every global problem, we have queuing, right? Waiting times, huge waiting times. And here, one of the things is transparency, right? So if you can see slots of doctors, if you can book yourself to GP or cardiologist, having a referral, that really makes a change. So speaking about the change, I will show you maybe this slide. Transparency, right? It's not enough to lock the data, you need to expose it in open data format dashboards. So this is what we learned. When you expose, we can see on the right, I'm sorry it's original in Lithuanian, but you can see a list of clinical specialties and waiting times, and you can make action to say, okay, well, what's the problem with ophthalmology here? and what is the problem with certain healthcare facility. So this is actually the whole cycle, which really a good tooling to help patients and to help policymakers. And I skipped the slide which was telling about importance of omni-channel approach, so that no one left behind. So it's not enough that it's possible to register yourself online with a computer. We launch mobile app, but we also need to keep traditional channels like a telephone. So everything integrates together. I don't know if it's gonna, okay, the most beautiful slide, it should have animation. No. Okay, ladies and gentlemen, the most beautiful slide was showing something unique in Europe. What was achieved by my country is a national data analysis platform, which aggregates data from different ministries and which was created during a crisis of COVID. There was a very nice animation showing in real time data flows from national registers, which are joined, pre-processed, and ending up in a certain dashboards for decision making, right? So we learned that it's not enough to have healthcare registers interoperable. We need to connect with Ministry of Interior, we need to connect with Ministry of Economy to know where a patient is located, what is his financial situation, if he's alone or not, what his medical status. And only then we can target meaningfully interventions. So this national platform required proper legislation. You know, in the EU we have GDPR. So that's one trick which you need to really carefully legally analyze. And then second important thing, to have all data flows interoperably connected together in one data lake. So this is quite an interesting experience. Now what we're working right now, you can see the list of initiatives which will be live this year. So most important is what we're doing when you have FHIR. When you have interoperability on syntactic level, you want to have it on semantic level. And here, the amount of work is limitless. And this is what we learned, that all shortcuts you're doing in the beginning, then we as a ministry have our goals and we want to start project as soon as possible and we do shortcuts. Afterwards, somebody needs to pay for that. So you need to return back and see that, oh, you don't have national lawing, right? Or you don't have other things. So this is kind of the things we're now catching up and fixing a semantic level of interoperability. So to finalize where we look forward, so basically we want to come to DPI architecture, which is not monolith, which is based on microservices, to decompose certain elements, to update our FHIR standard to the latest version, and we've selected a number of digital health initiatives to run on this platform. You can see a preventive program management solution, which we already have a successful pilot for breast cancer and cervical cancer prevention. And we want to top up with lung cancer and 4 other diseases, including cardiovascular prevention. Then we really want to enable a chain continuity of care for stroke and myocardial infarction, trauma, oncology clusters. So this is something very meaningful to join the institutions in one patient journey and to have digital platforms support that. And the last is emergency medical services to enable very quick information exchange, which what we learned is not enough to have a standard, right? Sometimes standard allows to pass data from EMS to hospital, but this data comes after patient comes to the hospital because it takes a lot of time to enter data. And to prevent this thing, you need to adopt workflow, how data is entered, in which phases, and how this will be supported by FHIR standard on interoperability level. So that's our initiatives. I know in short time it's impossible to be very deep and insightful. So please find me. My colleagues are also here. We'll be happy to answer questions. Thank you very much.
The Lithuanian case. You mentioned in the presentation that health facilities receive incentive use the free software from the government. May I know more detail about what kind of the mechanism that government provide this free software, either using the open source or the government develop or purchase the software and then available for free to the health facilities? And the second question, in this case, it is the case of using incentive for DPI. Are there any other incentive also implemented in Lithuania, not for DPI, but for other component that improve or increase the use of EMR in the health facilities? Thank you.
Basically, all countries who want to implement and have a take-up, they need to use kind of a stick and carrot approach, right? So in that sense, in Lithuania, it was developed system, developed solution, not commercial product. And API was exposed with a full documentation, with collaboration with vendors. Luckily, we're not in a situation when we have hundreds of vendors, with just a dozen. So it was quite easy to onboard them organizational-wise, and not so easy for them to change all their systems. So in that sense, that was a carrot. So we can collaborate. We give all the public goods available like API. And also we gave snippets, web portlets. If you cannot do in a quick time data viewers, you can use the portlets, right? So other incentives, well, I can tell you one secret incentive to use a national level online appointment system. So there are just not so many countries who did that. In Europe, I know North Macedonia, some countries are starting, my colleagues from Latvia are doing it as well. And the biggest problem as soon as you have a system is to force healthcare facilities to publish slots, availability slots of healthcare for outpatient consultations. And it's the most difficult task of this project. So again, stick and carrot. So one of the things, it's not enough to write a law or something, you need to really enforce that. So one of the things we tried last year, we put KPI of CEOs of clinics. One of the components variable was related to percentage of slots entered in national system. So if the percentage is low, then KPI goes lower and the bonus pay of the CEO goes also lower. So that's one of the examples.